Okay, everybody, we're gonna go ahead and get started. We have a pretty jam-packed program for you guys today. So good afternoon. Thank you all for taking the time out of your day to join us for this incredibly important and timely conversation. I do want to let you all know that this is being recorded, so that way people can look at it afterwards. For those of you who don't know me, my name is Shelby Leonard. I am a social epidemiologist, and I am a current public health planner at Healthy Capital District Initiative. And we work as part of the Population Health Improvement Program, working to help the counties with their county health improvement plans. And especially, we've taken on we've always been working on addressing disparities and letting our region know about disparities that exist. But we've really been focusing on that lately, and that's why we brought to you guys our race and health series that we have going on this month. So let's just go ahead and get started. So we know that racial inequities, they plague our country, including right here in the capital region. Like the rest of the country, large disparities exist in chronic disease rates and premature mortality. These are seen on all socioeconomic status levels and after controlling for other demographic variables. So this shows us that, these differences are not just a proxy for income differences. Black non-Hispanics experience premature death 24.8% more than white populations here in the capital region. And this is even worse when we look at it in certain regions, such as Saratoga County, where Black non-Hispanics make up 61% of premature deaths in the county, despite only making up 2% of the population of that county. So this shows us that these are incredible disparities. In light of recent events, many public health agencies and healthcare institutions are responding with statements affirming racism as a public health crisis. The fight for health equity and reduction of racial disparities is not new, but it is gaining new traction. Public health and healthcare are starting to look at things like structural discrimination in housing and the criminal justice system as barriers to health in Black individuals especially. But not much is being said about systemic racism that exists within public health, healthcare, and medical research. So it's time that we turn that magnifying glass on ourselves and understand how structural racism has shaped medicine and public health and the role that this still plays today. So with that being said, I'm excited and honored to share with you all our two panelists for today. They are rock stars in their field and incredibly ahead of their time. First, we have Jim Boyd, who is here to give us that public health perspective. He is the Regional Health Officer for Cook County in Illinois. He has spearheaded the CCDPH Roots of Health and Equity Dialogue Staff Development Initiative. He is on the steering committee of the Collaborative for Health Equity Cook County, which is one of 19 teams in the National Collaborative for Health Equity. He was a member of the Health Equity and Social Justice Committee of the National Association of County and City Health Officials. He was a fellow in the Human Impact Partners Public Health and Equity Leadership Cohort in 2014. He is writing a case study of the experiences and insights of National Collaborative for Health Equity Leaders for his dissertation at the University of Illinois in Chicago, School of Public Health. He has practiced at the local level in 3 public health departments in California and in Illinois since receiving his master's degree from UCLA. He was drawn to public health because of his foundation in social justice. Welcome, Jim. We're happy to have you.
Thank you. I'm very glad to be here. Thank you for those kind words.
And our second speaker, who I'm so happy was able to join us last minute, is Glennae Davis. She is the CEO of RX for Life, a health equity consultancy and education company. She holds a Bachelor of Science in Nursing from the University of Texas at Arlington. As a Black woman with a long, vibrant career as a registered nurse in critical care and solid organ transplants, she knows about bias and burnout in the healthcare industry. Glennae is also the founder of Nice Vision, which is a publishing company. She has authored 2 books, Yet Here I Stand, which is a memoir, and Bias and Burnout, which is a book for healthcare businesses. Welcome, Glennae. So we're going to spend about half of our time going into structural racism in healthcare and public health and the ways in which this occurs. And then we're going to spend the second half of our time focusing on what needs to be done to address these disparities. Any time that we have remaining will be for questions from the audience. You can put your questions into the chat box at any point, and we will collate those for the end. So let's jump right in here. So, these differences that we see in health outcomes by race, how do we know that healthcare is playing a role? And what do we mean when we say systemic racism in healthcare? Jim, I want to start with you.
Sure, I really appreciate that question. And again, it's a really great opportunity to be here and speak with you and my colleagues in the 6 counties of the Capital Region. You know what, I think when we talk about structural racism and systemic racism, kinds of structures as opposed to individual behavior, I think what we're meaning is policies that are created through political choices that distribute the resources that we all need to be healthy differently, inequitably, unfairly, in a racist way, in a sexist way, in ways that then give some folks who are advantaged more resources, such as money or sick leave or healthcare, and others who are disadvantaged through policy, less of these life-giving resources. So what that actually translates to here in the Cook County jurisdiction where I work is we've seen this since 2012, where we found a 13-year difference in life expectancy between the richest and poorest neighborhoods by quintile. And then even about a year ago, we saw a 30-year difference in life expectancy between 2 Chicago zip codes. These types of structural issues are driven by these outcomes are driven by things such as banks giving 80% of their loans to white, wealthy neighborhoods, which was recently the case here in Chicago with, I believe, Wells Fargo, and only a small percentage, I think it might have been 7%, to Black neighborhoods as far as lending. So even despite decades after the Community Reinvestment Act and the making illegal of redlining, we still have these large and I would say shocking structural inequities that in turn have life and death outcomes that we've seen over the years.
Thank you. Glennae, did you have anything to add? If you could summarize systemic racism in healthcare in just a few sentences.
Yes. Can you hear me okay?
Yes.
Okay, thank you. And thank you for having me. I didn't get a chance to say that at the beginning. So we know that healthcare is playing a role in a lot of these structural racism throughout all of our nation's workplaces because the employees experience spikes of stress hormones when they are facing discrimination on a job or white supremacy or biases that are implicit and designed to cause harm to another population. So when employees are going to their doctors for legitimate stress complaints, they are not being treated or provided with the information that they need to appropriately cope with discrimination in the workplace. There are studies that say that 65 to 95% of all doctor's office visits are for stress related, whether or not you legitimately have complaints of job stress like overt or covert discrimination to nuances that African American women experience, such as microaggressions. Those things cause myalgias and fatigue and headache and stomach aches. No information is given for people to appropriately cope, like I said, and yet we go on to have 75% of physical diseases from unhealthy emotions because we don't know what to do. So people are aware that there is a problem, but there is missing language. A sense of empowerment is gone, or just fear of risk of job loss. So, we're going to a doctor who treats disease, and so that role is not there for them to help a person prevent stress-related diseases. And this is where the disadvantaging come from across all socioeconomic statuses. Being African American means that our loss is suffered at a higher rate.
Thank you for that. All right, so I want to, start diving into some of the areas where we see bias within the healthcare system and public health. So I want to start with the most structural level and then move into systems and kind of work our way down to individual biases that we see. Jim, I want to start with you. When I think of the most structural sort of bias in healthcare and public health, I think of hospitals and departments where they're placed in the community, as well as the fact that community finances essentially determine hospital and public health funding. And I know you touched on this a little bit in your intro, but can you elaborate on that and any other sort of structural level biases you see?
Yes, sure, Shelby. And I think I want to pick up on what Glennae Davis so accurately referred to in terms of empowerment and power. I think this is something that public health leaders and workers are increasingly paying attention to. And it's these imbalances in power that I think are some of the root causes that we need to attend to. So I think if we look at, let's look at two kind of combined resources. One is pay, money, and also healthcare as a resource itself. Within the healthcare sector, and particularly hospitals, a recent journal article by Venkata Ramani and Himmelstein in the American Journal of Public Health documented the fact that low-wage workers, the wage structure of low-wage workers in hospitals particularly is both racist and sexist. And so with this, these obviously have health impacts because we know that there's a gradient. The more money you have, the healthier you are. So this research documented that 1.7 million full-time healthcare workers, particularly 1.7 million and their children, despite full-time in the healthcare sector, particularly hospitals, live in poverty. And the authors went on to document the research showing that this has health impacts. So I think that's one kind of way to view the need for workers, all low-wage workers, all essential workers, to have pay that allows them to actually have optimal health. And I think when we look at why this this pay structure, this unfair, racist, and sexist pay structure exists, is because of these power imbalances. So things like unions, things like social movements in the streets that we're seeing. Movements for social justice are ways to bring more power to folks who are exploited and marginalized and bear the burden of these unfair health impacts.
Did you have anything to add to that one, Glennae?
Yeah, as far as systemic racism in healthcare. So thank you, Jim, for that. And I think that it goes beyond just our low wage and low socioeconomic employees. It's also what I call our scholarpreneurs, who are highly educated individuals working, such as our doctors and our nurses. They too are at risk for health disparities through suicide and homicides and anger management and being diagnosed because they don't know what to do about handling bias on the job. That system is missing. And Alicia, she put a statement in, which I 100% agree with. It says physicians don't see the connection between racism and health. This is correct. Doctors' role is to treat disease. Racism and discrimination has been a perceived issue of the bearer of tyranny and bigotry and arrogance against the African American community. So no one has that system in place. So yeah, that was just my 2 cents on that part there. Our goal is to prevent preventable diseases, and I think through education that will be the foundation.
Yeah, I'm glad you brought that up, and thank you, Alicia, for adding that, because I think there is a bit of an issue here with physicians not understanding the connection between racism and health. And not only that, but just having a lack of knowledge of Black health in general.
Correct.
Think of medical schools and research. There is an incredible lack of diversity in the education that people are seeing. We're seeing doctors misdiagnoses all the time because they don't know what a rash looks like on a Black individual, for example.
Correct.
So did you want to elaborate on that at all, about sort of the history of kind of how we got here and how medicine and research and medical education are not really teaching or looking at what the actual differences are?
Yeah, I mean, it's a couple of things. One thing is that they study us, instead of having meaningful conversations with us. They study us and theorize us. And then another thing is, it is just as far as like medical laboratory, they use white rats and this hooded rat, and they've been using this white rat and hooded rat for since the 1800s to test medications and neurological pathways or whatever it is that they want to create in healthcare. And then the first group of people they want to put it on are Blacks. Well, you just used all of this medicine on a white rat that could not be further from us, and then you want to inoculate us with it. We already know the history of Tuskegee. We know the history of tuberculosis in Africa. Like, we know these things. And I think that if we want to really make medicine diverse as far as treating disease is concerned, then use 2 rats in the lab. That's my opinion of that, So, yeah. So I think that once we do that and we show that there is complete diversity and complete inclusivity between the cultures, and I don't even like using races because I happen to believe that there is just one race and that racism is a construct of science. I think that once we begin inclusivity between the differences of who we are, we can really start to see our similarities and stop with the disempowerment, the feeling of being, without power. Because I also don't believe that that there is an imbalance in power. That is also perceived. I relate everything to the workplace because it's so relatable. Everyone knows what stress in the job is, no matter who you are or what role you play. So that's how I communicate, so that people can understand that we all have the same set of rules. We may have different roles, but we all have the same set of rules, and we need to be able to abide by them, even though remaining compliant with them may cause levels of stress to spike. That's where our bias, our personal bias, come from, is not knowing how to respond to our own flight or flight system to make the best decision.
Tim, did you want to add anything on research or education?
Yes, I'd like to completely agree with Glennae Davis in terms of racism having no biological basis in science whatsoever. It is a social construct and has deep, and we can see impacts in terms of being deadly because of its social significance. And this is one of the things that I think you're pointing out rightly in terms of medical care research, medical research, and in terms of how race and racism is dealt with. And I think one of the articles I just saw about this recently is from the Health Affairs blog by Boyd et al. And it's a very, very useful, short read, and talks about all of us needing to be on the alert whenever there is a description of people experiencing higher rates of illness and premature death because of some sort of, anytime it's stated in terms of a genetic difference. And Boyd et al. In this Health Affairs blog point out that this goes back to a history, a horrible history where science, so-called objective science, was used to justify really horrendous treatment and torture of people, of Black people, of Jews, of people who were oppressed. So, but they point out how this tendency to talk about race and not talk about racism and still have this idea of some sort of genetic difference creeping into research is really existent now. And only in the recent times, I mean, they did a search and described the number of terms that come out. So I think that's something that all of us in public health also need to look at. It's not a problem of race, it's a problem of racism and white supremacy. And as far as genetic differences, these genetic differences do not exist between races. So I think that's what Ms. Davis was rightly pointing out, and I wanted to underline that.
Thank you so much for that, Jen.
Yeah, I'm glad you you brought up this difference between race and genetic biological differences. Speaking of that, I want to dive into that a little bit because there was a recent article that came out just in June on these clinical algorithms and these decision-making tools, and how a lot of these clinical decision aids that physicians use to help make decisions to determine risk for certain diseases or treatment, referrals, that sort of thing. A lot of these tools have turned out to have a lot of bias in them because they were doing this process of race correcting. And I don't know if you know, either of you know much about that, if you can elaborate on what that is and how essentially it really doesn't have much of a place in medicine, at least,
Yes. Yes. Would you like for me to go, or Jen?
Yeah, go ahead.
Okay, so when you talk about biases built into decision-making tools here in our nation, I think of Dr. Nadine Burke Harris, who is a Canadian American. She's a Black woman whose cultural background is of Jamaican descendant. And she's known, if any of you don't know who she is, she's known for the groundbreaking work linking adverse childhood experiences and toxic stress to harmful effects to later in life. She and I, our work parallel one another. And of course, she's a physician and highly revered. And, my experience is a lived experience, a personal experience of a woman who grew up in the inner cities and swam upstream just to hit this wall in healthcare, which prevented me from, was very adverse and attempting to let me progress beyond that after I had made it to this proverbial equal playing field, living the American dream. And it was from the chronic stress and the employment discrimination that I had faced on the job, which was in one of our nation's state hospitals, because of the workers' compensation system. And then, which landed me in psychiatry, because I'm like, something has to be crazy. Is it me? Is it the system? I couldn't figure it out, but it was the most difficult travail I've ever experienced in my life. And so on that note, I agree that toxic stress leads to disease. All of us know that. I think we all know that. But I disagree that we have about the language and the traumas of coming from our experiencing these things are adverse. Our childhoods and our experiences are inimical. They may be friendly or adverse, hostile experiences, but they really don't keep us from progressing unless we allow them to. What I found to be true is that the medical treatment plans are what's adverse, and preventing full maturation of the individual, whether it's the medications causing restraint of behaviors or lead to suicide and or cardiac arrest, all of which I've seen and all of which are known and stated side effects of these medications. So on that note, I highly caution against anyone without a background in these areas, making academic judgment calls on the needs of the people in these communities within our nation's inner cities without consulting someone who has done the work.
Yeah, absolutely. We do see so much of just academic researchers trying to make sense of what is happening. And, some of the ways they do that is through adding more points as Black individuals are more risky for this or that in these tools. And, there was one tool that based decisions off of previous healthcare spending, Well, historically, we spend far more money on white individuals than we do on Black individuals.
Right.
So if you base your decisions based off how much money you're spending on populations, that's not telling you who's sicker. So these
No.
sort of, these sort of things that we need to think about, and how public health professionals, when we interpret these sort of results, we need to really think about these things.
Right.
Jim, did you have anything to add here on any of the race correcting or these decision tools or health IT, anything like that?
It's not my area of knowledge. I just impact of structural racism within organizations that may develop these algorithms, but other than that, I'm really not familiar with it.
Yeah, it can be quite dangerous if we continue down this road.
Mm-hmm. Well, I definitely will after this webinar. I'm going to share some resources with all of you who attended, and I will include that new article in it, because it's incredibly fascinating, and they go through a bunch of different tools, and everything from the EGFR that we get with our blood taken, and things that predict kidney stones, things like that. So those are something that clinicians can actively think about when they are adding risk factors for race. I think if that's really necessary. So
yeah, I would love to see that.
So I want to move on to communication. So this is something that I put in a separate category because it is so important. And there's two sort of facets of it. With clinical communication, we have a serious mistrust, right, between providers and the Black community, and the way that the communication between the two was one of the reasons why we see bias in outcomes. And then, in regards to the public health department, this would relate back to outreach. And, a lot of outreach has to do with if they're going to the populations that are easier maybe, and not necessarily the ones that not reaching everybody. So do you want to elaborate on that at all?
Me or Jim?
Oh, you can start first, Glennae.
Oh, okay. Yeah, so I do. I love outreach programs. I think they're definitely necessary. However, I think we need to rethink the way that we're doing it. And, let me just say why. Because, you have so many people who show up for giveaways, and there's always this exchange. You come, you get your blood pressure done, you get your sugars done, but nobody is really sitting down learning. I personally think that instead of an exchange for, I don't know, whatever it is that they want to give away to someone for showing up to these outreach programs, is to make the exchange for knowledge, to sit them down, have a town hall like conversation, charge a nominal fee, 50 cents, $5. People appreciate value. And what that will do is weed out the type of people who are just there to get a handout. If they're there to get a handout, that's fine, but give them their handout and let them go, and invite them to come back when they're ready to invest in themselves. Just a little investment to sit down and to get an exchange of information will begin this healthy conversations, and will seed not just in the people who are coming, but the people who are service professionals to the ones that they're trying to bring up and make healthy, and then reallocate those funds back into their communities, their schools, pencils, pens, whatever. But I think that would be a great way to reach the people who do want some support to move forward in their life upstream battles for themselves.
Did you want to jump in at all?
Sure. I think that we're in the county health department. We've been trying to, in addition to including outreach, we've been really intentionally trying to build long-term trusting relationships with community power building organizations, with the idea that yes, we need to make the evidence-based arguments to policymakers and decision makers, but that we've been making, I think, great arguments for decades. And it's really an issue about the ability to actually pass policies and make policies real in the face of a more powerful opposition. And so that involves building community power. And in terms of, I agree in terms of it's really crucial to center communities and people who are bearing the unfair racist brunt of the premature mortality and premature morbidity and premature mortality and morbidity from COVID-19, from maternal mortality, from all these chronic diseases. I mean, we've known this literally for decades. So what has not happened? Here in the Chicago area, you know, we're having everybody's talking about the anniversary of the 1995 heat wave. So in the heat wave here, we had about 800 folks, mostly Black people, die from the heat. And there's a documentary about that I would encourage everybody to watch and read the great sociological treatment of that by Eric Kleinenberg. But these patterns have been apparent for a long time. So I think it's this issue of building power amongst community members, and we've been trying to do that in addition to communicating. And so I think that's a strategy that is crucial if we're going to kind of crack this nut of health injustice and health inequity. And if I might end, I just like to put an image in your all's head here. Fran Baum is a colleague from Australia, and she described, I think nicely, looking at a nutcracker. And so you have this hard nut, and how do you crack a hard nut? With the leverage. So what she describes is policymakers and decision makers and policy folks and electeds at the top of this, at one end of this nutcracker. And at the other end of the nutcracker is people power, community members, collective action by people led by their own people. And so I think it's a matter of health departments changing and respecting community leaders who are building power. And then between those two groups, we crack the nut and we open up into more health justice. And so here's the role for those of us who are leaders in public health, in governmental public health and outside, and also community members, because without either side, that nut is too strong and we won't crack it open.
I completely agree with you, Jim. Policy, yes.
Thank you for that. I want to just kind of finish up this section with asking you, Glennae, you know, provider level bias. This is something that when people do talk about racism in healthcare, this is usually the go-to. They'll be like, well, maybe it's just a couple of providers not really giving referrals or things like that. From a provider perspective, what do you think about this? Is this something that you know, we are seeing, or is this more of just like a lack of knowledge and understanding of Black health in general? What are your thoughts?
Well, implicit bias is a problem within our work environments. My work environment for the past 30 years has happened to be the healthcare industry, right? The healthcare system. And I have been on the receiving end on those stereotypes, both as a healthcare provider and as a healthcare consumer. Implicit bias causes hurt feelings, it lowers confidence and disempowers people, causing vulnerabilities and a complacent attitude, and like, you know, what point is it to move forward because this hurts, or a lack of will to do anything better, and a lack of will to hope for more. So implicit bias within the healthcare system is a real big deal, because they don't think, white doctors do not think. And one doctor told me he didn't see a reason for me to be using my thumb at work when I had got injured. He said, I don't see a reason for you to be using your thumb. And I'm like, what? what? Write that down.
Mm.
Like, write that down in that record right there. And, and looked at me with this gaze like he was just completely misunderstood as to how I could be having a conversation with him in that moment. Or why was I even a nurse? So it hurts. But my skin is a little bit tougher than other people because of my own personality. Uh-oh, can you guys hear me?
Yeah.
Oh, okay, it went out. My speakers had went out. And so what I've come to understand about implicit bias is that it is personal, but then it is academic also. And we have to decide what side we're going to be on because clearly America is a business and so is healthcare. And we have to decide whether or not, we're going to teach America's citizens how to engage in trade, or else there's going to continue to be what I call this great rape. This rape that's not just physical, but spiritual in nature, that destroys communities, our consumers, and our next generations. Like right now, I see our nursing students testing for COVID outside the front door. Some people are like, well, at least I'm getting my hours. And then I'm like, you need your experience. Or you need to take a time off, because you wasting your time right here is not doing anything to build your future. And it certainly isn't doing anything to make sure that I have the best nurse taking care of me. God forbid I end up in the hospital. So we have to think about the things that we are doing. So when we talk about Black healthcare, we must also include his and her personal relationship with the living God. Why? Because all the systems that I encountered going through what I was going through would have disadvantaged me had I not applied the gospel. And that's just the fact.
All right, so I want to switch gears a little bit, but before I do, I want to talk just briefly, kind of reiterate how this happens in healthcare. We have people are experiencing different qualities of care due to these systemic differences. And then, they're experiencing different level of care from their providers as well, in regards to referrals and treatments due to both individual bias and these biasings and tools. And these, these outcomes create this mistrust between healthcare and public health and the Black community. And this is going to initiate people from getting care. And we have to remember that this is not their fault. This is our fault. This is our problem to fix, to build that trust back with these communities. So moving on to that sort of thing, let's talk about what can we do. Jim, I want to start with you and talk about your work with the Collaborative for Health Equity, which makes addressing structural racism and building community power an explicit element of its mission. Can you tell us a little bit about this, how it came to be, and what type of effects you're seeing?
Sure, I'd be happy to do that, Shelby. And first, I just want to acknowledge really the moving statement that Glennae Davis just related to us. The fact that she had a white healthcare provider actually dismiss her need for optimal health in a clinical setting. And I think to me, this underlines the fact that those of us with privilege, be it white skin privilege, be it educational privilege, be it gender privilege, our privileges blind us and lead us to think that we know better, or what people actually tell us is somehow less important. And I think it's something that folks with privilege, white folks, need to wrestle with and call out examples of racism and systemic racism. And so that's something I just think it's very, very important. And I'm so sorry that happened to Glennae Davis, and I appreciate her sharing that.
Thank you so much for that. And I agree. Yeah, we have to, anybody with privilege needs to be able to, call that out and wrestle with why we think that way about someone else, why they're in that situation. So yeah.
You're definitely not, the only one to experience that, by any means. One
Yeah.
woman I was talking to when I was preparing this had mentioned that she was working in the ICU unit or the NICU unit, and she repeatedly would see Black mothers getting turned away. They would say they had pain, and they would get turned away. They're like, "You're fine, you're fine, you're pregnant,
Right.
you're just pregnant," and then she would just see them die because essentially she watched both the mother and the baby die right there. And so, I mean, these types of effects, I mean, they're severe and they're really happening. And this is, like I said, unfortunately, we're not, the alone in that. And I do appreciate you sharing that story.
Thank you. Right. Sometimes we do feel alone because it's like this can't be happening to other people, but it's happening at an alarming rate, and it's as powerful as the police officer using his 9mm Glock to take the life of people. But this is done in the healthcare system. It's the same. It's the same abuse, the same violence.
Now we can go back to Jim, to your question there.
So I think this is piggybacking up on this and to your question about Collaborative for Health Equity Cook County. Its origins stem from Dr. Gail Christopher, who was one of the intellectual founders of what was then called Place Matters. And later, its current director is, it's also headed by Dr. Christopher now, but in the recent past, Dr. Brian Smedley was the director of what was then would later change to be called the National Collaborative for Health Equity. And I think its purpose was to draw together public health department teams led by the public health department, but also really community members to tackle the social determinants of health, to tackle structural causes, including structural racism, and find out ways in practice that we could move public health to a more effective practice to transform what we were doing in teams and to kind of serve as a laboratory, a community of practice across the country. And at one point, I believe there's 19 teams. There's 18 or 19 teams now. And so for about at least 10 years, the Collaborative for Health Equity Cook County has been in existence. And we've done things like focusing on food deserts. We published a paper, or a report rather, together with the Chicago Department of Public Health and Virginia Commonwealth University, in which we documented the effects of racial residential segregation, and in the fact that, I mentioned this earlier, between the richest and poorest neighborhoods by quintiles, there was about a 13-year difference in life expectancy. And so this had, we were able to publicize this, and we made a number of policy recommendations. More recently, we've been focusing on a number of issues around protecting immigrant rights and immigrant health and other marginalized populations from the effects of mass deportation and really the violence and fear on what I would call a threat to public health, represented by this policy of mass deportation. So a couple of years ago, we were invited to present some of our work during the American Public Health Association. It was a special 90-minute presentation hosted by the Spirit of 1848. And one of the things that we presented was results of a survey that we did, which showed a range of ways in which providers of social services and healthcare for Latino folks in Metro Chicago reported that there was huge amounts of fear among the Latino community that resulted them in not wanting to leave their house, not wanting to come in and get health care, being afraid of getting deported if they left their house. And all of these things are as Ms. Davis pointed out, really factors around psychosocial harm and toxic stress, in addition to not accessing healthcare or not accessing kinds of social support provided by human service agencies. Most recently, we've also helped our Cook County Department of Public Health to write a group sign-on letter. We had an open letter which over 100 people signed, which was later turned into an op-ed signed by Dr. David Ansell and Dr. Linda Ray Murray, calling upon municipalities to opt in rather than opt out to a county ordinance increasing the minimum wage. There's a minimum wage increase in Cook County. Home rule suburbs in our jurisdiction, of which there's like about 125 suburbs. These home rule towns and suburbs are able to opt out, and unfortunately, many of them have. So we've worked on that, and then also we've recently taken on again the effect of ICE incarceration around the state. There's some facilities here in the suburbs in which people who are arrested and detained by ICE are processed and held. And we actually have a county in our state, Pulaski County, that has a contract with ICE and receives millions of dollars from this contract that goes into their county's budget. And so we think that our Illinois Department of Public Health, again, this is the Collaborative for Health Equity's position, of which I'm a steering committee member and proud of that, to provide that along with my coworkers, colleagues rather, Susan Avila, Wesley Eplin, Linda Murray, and Lillian Jimenez, and many others, to call attention to our statewide, really, I would say, kind of collaboration with ICE, which is a threat to the public's health. So we've worked on that with other kinds of social movements around the state. I think this is an example of a coalition working on social justice, taking a structural point of view based on the science of the social determinants of health, and the Cook County Health Department's relationship to the Collaborative for Health Equity Cook County is one of participation, but not control. And the National Association of County and City Health Officers refers to this as a best, kind of a principle of health equity practice, that health departments can participate in coalitions led by community members as an equal partner, not as a controlling partner. And that sometimes for health departments, that's easier said than done.
Thank you for all that incredibly important work that you were doing. And it's really great to watch.
Thank you.
You know, I want to talk a little bit about training. Jim, I know we talked about this, and you have done a lot of different trainings on racism and structural racism. Firstly, how effective do you think that training is on reducing these implicit biases? And what are some of the intro concepts you would recommend? We had somebody in the chat mention implicit bias testing as a way to open people's eyes. What do you think about all of this, about training in general?
I think training is incredibly important. And I think but I think it depends on how it's done. I think training that is done in a lecture style, where someone desk and just listens to facts and is expected to maybe, if you're online, to hit a button for a multiple choice question, I think it's not as effective as training in which, and in fact, that's why we called our initiative dialogues in small groups. And I think the research on learning will bear that out, especially in terms of transforming our own existence and growing up in a country which is based, as Glennae mentioned, on a history going back to 400 years to enslavement of Black people and to stealing of indigenous native people's lands and destroying cultures, that this is really his part and parcel of influencing how we view things. So, and I guess when I say we, there are multiple we's, right? There's a recent article, again, I think it's very, very powerful, the Dr. Bowleg, B-O-W-L-E-G, where she makes a compelling case, and I think a really challenge to us in public health, that we are not all in this together based on these rates of COVID inequities that are 3 and 4 times higher for people of color, for instance. So I think this idea of the multiple we's and the ways in which privilege affects how we relate to each other, how we talk to each other, how we work and carry out our public health strategies, can be dealt with only in trainings and really in dialogues that discuss history and discuss things like in groups and out groups, oppressed groups versus advantaged groups. And so I think that now is the time for me to make a plug for the Roots of Health and Equity.org. This was something that, through the decision of our former director, Dr. Terry Mason, was a mandatory training in which we did divide up our 130 some staff into about 12 groups. And because there was actually $0 budgeted for this, these dialogues, instead what we did is we used our own staff, and we trained 24 co-facilitators. So each of the 12 small groups would have 2 co-workers. Those of us we know the Cook County Health Department. Many of us do know each other. We know our pluses, our institutional history, as well as our weak points where we have room to grow. So there was a certain amount of credibility built into this, but nonetheless, given these difficult topics, I would say difficult for many folks that often people would rather avoid talking about: racism, structural racism, other kinds of injustices, that we wanted to have our facilitators prepared, familiar with the material, and also kind of have basic facilitation skills in order to deal with, make sure that there was respect for differences, different points of views, and have a productive dialogue. We actually met for about 7 or 8 times. We had an introductory meeting. Each meeting took anywhere from an hour to an hour and a half. We did our best to not disrupt our regular clinic and work schedule. Because of our logistics, we had to meet in 4 different locations. But I think some of our evaluation showed that it was very useful. People felt good about it. It opened some people's eyes to unfair privilege, to racism and other kinds of oppression. Kind of, I guess, one term is intersectionality, but how a lot of these privileges and also ways in which someone is marginalized kind of overlap in a single person. And so this was very useful. And the last couple of meetings we asked our staff to make suggestions themselves about how we should go forward as an agency and apply our new insights and knowledge. And we had just finished that, and COVID-19 struck. We went into kind of an emergency preparedness mode. And so unfortunately, there's been kind of a lag. We did plan to have this for all new employees would also go through this. But I would encourage folks to look at rootsofhealthandequity.org. They've added 2 new units. One of them is on narrative, and you talked about communication. And I think the narrative is a really important topic for public health work. What do we actually say? What words do we use? Do we only talk about race, or are we clear and we talk about structural racism and racism? And for instance, let's say me as a white male, How do I interact with my own coworkers? Or am I possibly regenerating and reproducing inside of my own agency the very structural racism and racist behaviors that we want to call out outside of our agency? We've got to transform ourselves inside I would say first, or as much as possible as we work with folks in the community. And one last thing I might want to mention is our agency also used a wonderful series, which I think is free online. You can get them in DVDs, and it's called Race, the Power of an Illusion. Race, the Power of an Illusion. It's from California Newsreel. Incredible. It's an incredible way to engage in the discussions and talk about history of racism and exclusion in the United States, and what some of the science says about this.
Thank you for that. Thank you for sharing some resources, because I know that our participants are definitely looking for some, and myself included. Now is the time we're all trying to kind of educate ourselves on this, like we should have done for a while, but better late than never. But before I go on to, we're running out of time, so before I ask you the kind of like last rapid question, I did want to ask you, Jim, about your work with social justice groups. I mean, this is something that we don't see too much. We don't really see like public health departments working with social justice groups. So do you have anything to say about that? Would you recommend it? Were there any challenges? What does that relationship look like?
I think if public health folks are not working with social justice groups, we're violating our public health ethics. I've looked at the documents on ethics. There's a recent one just out last year. The previous one talks about the need to highlight and create spaces and support groups who have been excluded from policymaking processes, and that these are root causes. So I think it's important for us to fulfill and take full advantage of the opportunity that we have to do our work based on social justice values, on racial justice values, and that some of these ethics documents are ways that really fully explore the implications of working for social justice. I think the way to do that, especially now, is wherever we are, is to reach out to community members, particularly, I would say, anybody who calls themselves a community organizer, a labor organizer, or someone who says, these evictions that are taking place are wrong. Bless you. These evictions that are taking place are wrong. Housing is a human right. The right to clean and affordable water is a human right. I think a lot of folks who are doing this type of work really don't consider their work to be health work, or for that matter, public health work. And we don't need to actually emphasize that. But if you seek out folks who are trying to make things more fair, that is doing social justice work. And in order to do that, I think all we need to do is pick up the phone, make a phone call, ask to have maybe a virtual cup of coffee with somebody. And, folks call this maybe a one-on-one. I might introduce myself to someone who's working on police violence, or I might work with somebody who's concerned about education and how can we be safe when schools don't have enough funding to maintain adequate sanitation, or don't have adequate 6 feet of social distance, or not enough PPE for teachers and students, or parents who are saying, how do I get a test? How am I able to protect my family if I'm tested positive in my essential service job? How am I supposed to complain if my employer is not allowing me to have 6 feet of social distance? What do I do? These are all questions that relate to social justice. And I think that by making an attempt at this, a one-on-one, reaching out to leaders and saying, I work in public health and you're doing social justice work. How can we work together? Because your goal is what our goal is, and listen. So I think the listening and building up relationships of trust over time, and not building up relationships based on a problem that I have chosen, but rather an issue of concern that a power building or base building group has chosen themselves, is a way for us to begin to do this social justice work.
Thank you. I completely agree.
Mm-hmm.
I know we're running out of time. I want to give you, Glennae, a last chance to kind of address this. You know, how do we go beyond scratching the surface of social determinants of health and equity, and actually tackle these root causes, including structural racism? What can healthcare professionals do?
Yeah, so healthcare professionals can definitely do the training for implicit bias, which should be in-person workshops with dialogues with everyone from the stakeholder of that company to the little boy and the little girl from the inner cities, and really just like role play, figure out how to get to the center of understanding and listening to one another, because doing this virtually online is not going to meet the standard for where this country is going post COVID and post civil unrest where we are now. We want to get back to a new normal. There's not going to be one. This is going to be a change, and we have to decide what health equity looks like for everyone who's left, everyone who is left. And you know, so training, we say in healthcare, like I'm a nurse and I work in ICU, and I know that it takes deep nerve root stimulation to elicit a small response from a person who is unconscious. So it's going to take a lot of work. And I don't feel that we should be spending as much time on the person with unconscious bias as we should with the people with an awareness, because we have to find solutions and we have to move this country forward before we die. We cannot keep playing around with trying to wake up something that is unconscious to it. We have to pay attention to who knows what and what's next. You know, and we're all over the place with our own ideals and our own situations and our own backgrounds. But the one thing that is just and the one thing that is true is that we want equity, all of us. We want to be heard. We want to be understood. We want to go to work. We want harmony. You know, not everyone is meant to be entrepreneurs and just leave that workplace, but we have to figure out how to create a culture of employees being empowered to prevent this institutional racism from impinging on their own consumers. And for my industry and your industry, those are people and their health. So we have a lot of work to do with that. And I speak to my upstream factors in my book. Yet Here I Stand, My Journey from Bondage to Liberty. And then I have the next one that is soon to be released, The Bias and Burnout, 10 Power Moves for Healthcare Workplace Equity. I used those 10 power moves. Of course, it was in retrospect because I'm like, how did I get through all of that? And so I put it into new concepts and helping people to understand what to do. My clients, some of them have used them and they have had great results. They did not get disadvantaged from their situation. And then I still have some who is like crying and calling, they feel like a slave, but they can't open up their mouth to confront the person who's causing them harm at work, because they're afraid of losing their job. You know, people don't realize that even if you do the right thing, natural laws are going to come in. Like you're going to be okay. But if you don't do anything, that alone is going to eat at you and tear you to pieces. So, yeah, I mean, I would like to offer, you know, for training, for people to come into a webinar and get to know me a little bit more in this new branding in healthcare that has just been born for a time as this. And so I look forward to meeting and talking to more of you to dismantle white supremacy in healthcare. You know, just scratching the surface is education. We all have to do our shadow work. You know, it's not just Black people who are psychologically damaged from slavery, it's white people who are also psychologically damaged from slavery. And we have to change that. We have to get to that nut in the middle, right, Jim? And have those healthy dialogues about workplace and healthcare. You know, it's no perfect moment than this time right now in history to get to this equity that we all want and to get rid of white supremacy out of our institutions, to recreate new systems that's going to recreate a new thought and new life and harmony for people.
I fully agree, Glennae. Thank you so much.
Mm-hmm.
Thank you for that insight. I know I, for one, am excited to see your book when it does come out.
Yeah, thank you.
About it. So I do want to just quickly ask if anybody in the audience does have any questions, put them out now. We are running out of time. The only question that I saw in there so far was if anybody knew any resources for young people in schools on how to educate them on this stuff. Do either of you know of anything in that realm? I know there was somebody who responded in the chat with a book.
Right. You know, I just think that part of our problem with educating people is that we continuously look at the history instead of trying to come up with the solution. The history is very important, but if you really look at it through a lens, then you'll know that we're still in the same history. Like nothing's changed except for employees are now getting compensated for the work that they do, but we're still not really bargaining in the workplace and handling business as we should. And I think that children in school should also be open and aware to how the system is affecting them and speak up about the bullies in school and, you know, social media and things that is kind of derailing them from their best life. So I don't know. We have to come up with some resources for that.
I'm not sure about in terms of the age level, but I think one option is the Unnatural Causes is Inequity Making Us Sick series. Has some good film segments and also has a guide to go with it, also from California Newsreel. So that's Unnatural Causes is Inequity Making Us Sick.
And I will include this, all of the ones in the chat that people mentioned, and some resources I found in a follow-up email to you guys, as well as the recording to this webinar. I want to thank you both so much for being here. I found it incredibly informative. I'm sure other people in our area did as well. You know, you guys are joining us from Chicago and LA, so we really appreciate your expertise. We are continuing this series. We're doing a series of 4 presentations on race and health in July. And our 2 of them are for community health workers and care coordinators and people that are specifically working with people in the community. So those are more of like a training. But we do have another informative webinar like this coming up at the end of the month. It's going to be on racism and mental health. We're really going to be getting into how racism affects health and talking more about, you know, what Glennae mentioned about stress and things like that. We have some another set of really awesome speakers who do research on that and going to share their perspectives. So I look forward to seeing as many of you guys there as possible. And thank you again to both of our speakers.
Thank you so
much.
Thank you,
Shelby,
really
for having me.
Thank you very much.
It was great. Thank you.
Great to meet you, Glennae.
Yeah, all right, James. Have a good one.
Thank you, Shelby, and thanks to everybody in the Healthy Capital District Initiative.